Picture this. A 42-year-old female presents to the ER. She's got a history of obesity, and she's leaning over in absolute agony, severe pain right in her right upper quadrant. And this happens right after she enjoyed a heavy, fatty meal. It's a totally classic presentation, right? Salam, welcome to A Little Push 5 Men's Medical Mnemonics. So let's unpack this classic clinical vignette. To really grasp why our patient is going through this intensely painful biliary colic, which, by the way, is caused by a stone temporarily blocking her cystic duct, we've got to look at her risk factors for gallstones, or cholelithiasis. Now, a lot of us start out in med school learning the basic 4 Fs, right? But to truly master this topic for the wards and totally crush the boards, we need to upgrade our knowledge to the comprehensive 8 Fs. Let's break down the first half of this cognitive scaffold. These first 4, they're your major metabolic triggers for cholesterol stone formation. First up, female. Gallstones are just significantly more common in women. Number 2, fat. Obesity, typically defined as a BMI over 30, is a massive metabolic trigger. Third, 40. The incidence of these stones increases with age, classically peaking right around or just after age 40. And the fourth F is fertile. Multiparity, which means having had multiple children, is a key risk factor, mainly because of all those hormonal changes that happen during pregnancy. Okay, so building on that foundation, let's jump into the advanced board-level Fs. These next 4 are absolute high-yield gold. We've got fair, which points to an increased incidence seen in white and Native American populations. Then, feeds. This refers to total parenteral nutrition, or TPN. Think about it. When patients get all their nutrition intravenously, their gut never stimulates the gallbladder to contract. That leads straight to gallbladder stasis, sludge, and eventually stones. Next is fasting. Rapid weight loss, like the kind we see after bariatric surgery, actually causes the bile to become supersaturated with cholesterol. And finally, fibrates. This class of lipid-lowering meds increases cholesterol excretion directly into the bile, which just massively spikes the risk of stones. When we image these patients, we're typically using an ultrasound, which is absolutely the best initial test for this. You're looking for a clear, echogenic gallstone sitting right there, creating a really distinct dark acoustic shadow directly beneath it. It's almost like a little rock blocking the sound waves. But hey, here is a major board alert for you. Watch out for the secret 6th F, which is febrile. If your patient has the classic Fs and suddenly shows up with a fever, an elevated white count, and a positive Murphy sign, well, that diagnosis has likely progressed from simple cholelithiasis to acute cholecystitis, meaning the gallbladder is now inflamed or actively infected. Now, here's a totally crucial number you need to burn into your memory. 80%. A massive 80% of patients with gallstones are entirely asymptomatic. Crazy, right? They're just walking around with these stones and don't even have a clue. For these folks, we generally just recommend observation. Elective surgery is really only reserved for symptomatic patients or those with very specific high-risk conditions, like a calcified porcelain gallbladder, which carries a scary risk of carcinoma. It's also super critical to remember that not all gallstones are created equal. Those 8 Fs we just went over, they primarily apply to cholesterol stones, which make up roughly 75% of cases in Western countries. But what about the other 25%? Well, those are pigment stones. If you're evaluating a patient who just doesn't fit those 8 Fs, let's say a really young patient, you need to totally shift your diagnostic thinking. Black pigment stones are made of calcium bilirubinate and are heavily tied to chronic hemolysis or cirrhosis. Meanwhile, brown pigment stones are generally associated with biliary tract infections. All right, let's lock all this knowledge in with a rapid review quiz. Listen closely, here's the question. A young patient with sickle cell disease presents with gallstones. What is the most likely stone composition? Take a moment to really think about it. Got your answer? The answer is pigment stones, specifically calcium bilirubinate. Remember, sickle cell disease causes chronic hemolysis, and that leads to an overproduction of unconjugated bilirubin that basically precipitates out into these black pigment stones. So, before we wrap up, ask yourself, what other hidden dietary or lifestyle factors might be silently setting your patients up for biliary disease? I really hope this mnemonic makes your time on the surgical wards and your board prep just a little bit easier. Keep reviewing those 8 Fs, keep pushing yourself, and thank you so much for trusting us with your learning journey. Until next time, salam.